Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with Dr. Anees Chagpar. Yale Cancer Answers features the latest information on cancer care by welcoming oncologists and specialists who are on the forefront of the battle to fight cancer. This week it's a conversation about new treatment options for liver cancer with Dr. Tamar Taddei. Dr. Taddei is a professor of internal medicine and digestive diseases at the Yale School of Medicine, where Dr. Chagpar is a professor of surgical oncology.
So, Tamar, maybe we can start off by you telling us a little bit more about yourself and what it is you do.
So I am a professor of digestive diseases, which essentially means I'm a board-certified gastroenterologist. Gastroenterologists have a very broad field, so I chose to specialize in liver disease and specifically end-stage liver disease and liver cancer, which afflicts people with cirrhosis. So I focus my clinical work on liver cancer, and that's been an incredibly lovely part of my career. I do also a lot of research and a lot of, administrative work to run the section.
Okay. So maybe we can start off first of all, by kind of defining liver cancer. I think many people think about liver cancer when they have a cancer from somewhere else that spreads to their liver. But my perception is that the disease that you study most frequently is a different kind of liver cancer, primary liver cancers. Can you talk a little bit more about the distinction?
Oh, yes, absolutely. It's a very important distinction to make. In fact, many people will say, my cousin or my friend or whoever had liver cancer, but it turns out it was metastatic to the liver from another primary. And that really is the most common presentation of liver masses in the sense of malignant masses. They're actually metastases from another primary site. However, primary liver cancer is actually a very deadly and nowadays more common than it had been cancer. There are two different types of primary liver cancer, and it really depends on where the cancer originates from. Cancers that originate from liver cells are called hepatocellular carcinoma or liver cell cancers. And then there's cancers that originate from the biliary cells. Those are called cholangiocarcinoma or bile duct cancers. And they're very different cancers. They're treated very differently. But hepatocellular cancer is the majority. That's about 90% of primary liver cancers, whereas the bile duct cancers and much rarer cancers account for the other 10% or so.
And so paint us a picture of, who gets these primary liver cancers? What are the risk factors? Are genetics involved? Tell us a bit more.
Okay, so let me focus primarily on hepatocellular cancer because that is the most common primary liver cancer. And there's a lot of problems in terms of identifying who's at risk because about 90% of hepatocellular cancer in the United States arises in people who already have the major risk factor of cirrhosis or scarring of the liver. And the problem is many people may have cirrhosis but not know it. And so even though we know that we should be performing liver cancer screening in people with cirrhosis, the problem is if people don't know they have cirrhosis, we might be missing quite a few people who need to be screened. So this is really a major issue. It's really when you think about, a cancer cascade, you want to think about, prevention, screening, diagnosis, and treatment. And if we can't even figure out who we need to screen, we may be very much behind the eight ball in terms of detecting these cancers as early as possible, which we know correlates well with survival. If we can detect the cancer early, we can treat the majority of these cancers. And so we have to raise awareness for both cirrhosis, which is the most important risk factor, but also the importance of screening in people with cirrhosis, because many primary care docs don't know to screen their patients with cirrhosis. So there's a whole lot of work we need to do on that sort of prevention and screening arm before we even get down to the diagnosis and treatment phases.
And so, just going back to one of the comments that you made, which was, hepatocellular cancers tend to occur in people who have cirrhosis, but many people might not know that they have cirrhosis. So that's kind of worrisome.
Mhm.
How do you figure out whether in fact you could be walking around with cirrhosis? Are there risk factors that you should be looking for, signs or symptoms? Should this be something that your doctor looks for on routine blood work every year? How do we make that diagnosis?
So that's an excellent question. And I think that the issue is the epidemiology of cirrhosis is changing fairly rapidly. So in the United States, the primary reason for developing cirrhosis and hepatocellular carcinoma, in terms of, sort of the era before the 2015s or so, was hepatitis C. I should start by saying that alcohol-related cirrhosis is still the number one cause of cirrhosis in the United States. But hepatitis C was very prevalent, was very hard to treat. And then around 2015, we actually developed treatments called direct-acting antiviral treatments for hepatitis C. And we've been trying to get those treatments out to mitigate the risk of developing cirrhosis, because cirrhosis can develop at a variable rate in people with hepatitis from any cause. So I'm talking right now about viral hepatitis. But we can cure hepatitis C. So really, the CDC recommends hepatitis C screening in all adults. So if you haven't had a hepatitis C screen, you should definitely have that, because your virus can be cured. And really, most people with hepatitis C don't have any symptoms at all. And in fact, many people with cirrhosis have no symptoms until their liver begins to fail. But the other major risk factor that, leads to inflammation and scarring of the liver, which is on the rise, is metabolic dysfunction-associated liver disease. So this is termed now metabolic-associated dysfunction, steatotic liver disease. It's called MASLD. So it used to be called non-alcoholic fatty liver disease. But really, the issue with this epidemic, which really is becoming an epidemic, it's linked to being overweight, having certain risk factors like diabetes, a very strong risk factor, hypertension, hyperlipidemia. Many people have all three. And those people can actually develop liver inflammation that leads to scarring over time and eventually cirrhosis. And so there are now guidelines for primary care docs to really think about liver disease in patients with metabolic risk factors. And these are gaining traction. And so the hope is that more primary care docs will be thinking about this in their patients. I think as a patient, if you have those risk factors, you really ought to ask, am I at risk for liver disease? Are you checking my liver, panel? And we have a very simple test that can be run just based on, a blood count. It's called, and a liver panel, which is called the Fibrosis 4 score. And that looks at AST, ALT, platelets, and age. And that can give a score which would make a primary care doc think, this person may have liver inflammation or scarring, and they should go see a liver doctor to really be assessed for fibrosis, and then, be put on a pattern of sort of routine checks to see if they have fibrosis, and if they do, if that's progressing towards cirrhosis.
I think it's one thing to say you're at risk. But when you start talking about this metabolic associated liver disease and went through the list of obesity, hypertension, hyperlipidemia, I sat there and I thought, geez, that describes a whole lot of people in this country. And it's one thing to say you're at risk for liver disease, but is there anything that we can do, if we fit into that bucket, that we can do to prevent cirrhosis or to prevent the progression to liver cancer?
So I would say the most important thing to do is to think about what you can change in your life. So a lot of adult life is a cumulative exposure to different risk factors, and that can be being overweight, that can be, developing consequences of being overweight. And a lot of this is really public health and prevention through, changing the way we do things, the way we eat, the way we, get exercise. And I have to say about 100 million Americans are, probably have some degree of this steatotic liver disease. And we know this by big population studies that have looked at screening, imaging screening done for other reasons, CTs of the lung, which are done commonly in adults to screen for lung cancer. They've found fat in the liver on ultrasound, et cetera. So if 100 million Americans are at risk for steatotic liver disease, about a quarter of those people will develop significant inflammation in their liver, so 25 million. And a proportion of those are on, basically at very significant risk for the development of fibrosis and, ensuing fibrosis and cirrhosis. So it is a huge number. We're very concerned. I think the more that people can concentrate on healthy eating, adequate exercise, if they already have diabetes, controlling their diabetes. And we have now a number of different medications that have definitely helped to get diabetes under control and even obesity under control. So I think we have a lot of both lifestyle modifications we can make as well as pharmaceutical, or drug interventions we can do in the sort of obesity and diabetes realm. So I guess that answers that question. I think the other thing is if you've never been tested for hepatitis C, you should be tested because that's another risk factor that you could mitigate. And many of our patients with hepatitis C, even those, of course, who've been treated, we still worry about progression of liver disease if they are overweight and have diabetes, hypertension, et cetera. And then I think finally, the other thing that's important is alcohol, right? So, if you have other risk factors and you're drinking heavily, I think that's another modifiable risk factor that you can sort of take off the table. And certainly in anybody with advanced scarring of the liver, we advise them not to drink at all.
So just to put a point on it, let's suppose you're listening to this show and you're thinking, I've been thinking about losing weight because I am overweight or I am diabetic or I am hypertensive or have high cholesterol or a combination of all. If you actually do make a change and you're in your adult life, will that reduce your chances of cirrhosis or potentially reverse it? Or is the damage already done such that, those are good things to do for your general overall health, but once cirrhosis is there, it's kind of there? So
that is a very important question and one that has a long answer, but I'll try to sort of simplify it. So cirrhosis is really a histologic diagnosis. It's made based on a liver biopsy. And we don't do liver biopsy much anymore unless we have a really good indication for it because we have a lot of non-invasive tests for fibrosis. And so instead of calling cirrhosis, we now call it, compensated advanced chronic liver disease. And that's based on liver stiffness measurement, which we can do. It's basically sonar of the liver where we get a stiffness measurement back. And it's also called transient elastography. So I would say that if you have early fibrosis of the liver, it's very reversible and you could lose weight and see those numbers get much better. It's when you already have established cirrhosis that you really may have gone beyond that reversible state. And that's something that really a hepatologist will help you determine with liver stiffness measurements and with a clinical exam as well as blood work.
Fantastic. Well, it's good to know that we can start to make a difference. Right now, we need to take a short break for a medical minute, but please stay tuned to learn more about the care of patients with liver cancer with my guest, Dr. Tamar Taddei.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their prostate and urologic cancers program is comprised of a team dedicated to managing the diagnosis, evaluation, and treatment of urologic cancers, including testicular cancer. SmiloCancerHospital.org. Over 230,000 Americans will be diagnosed with lung cancer this year, and in Connecticut alone, there will be over 2,700 new cases. More than 85% of lung cancer diagnoses are related to smoking, and quitting even after decades of use can significantly reduce your risk of developing lung cancer. Each day, patients with lung cancer are surviving thanks to increased access to advanced therapies and specialized care. New treatment options and surgical techniques are giving lung cancer survivors more hope than they have ever had before. Clinical trials are currently underway at federally designated comprehensive cancer centers, such as the BATTLE-2 trial at Yale Cancer Center and Smilow Cancer Hospital, to learn if a drug or combination of drugs based on personal biomarkers can help to control non-small cell lung cancer. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Welcome back to Yale Cancer Answers. This is Dr. Anees Chagpar, and I'm joined tonight by my guest, Dr. Tamar Taddei. We're talking about the care of patients with liver cancer. And right before the break, Tamar was telling us that, there are people who are at risk for liver cancer, who are at risk for cirrhosis, who may not even know that they have this. So it's really important to have a conversation with your doctor about your risk, especially if you fit into any of the number of categories that she gave us, whether it was hepatitis C or alcohol, or perhaps more frequently these days, being overweight, hypertensive, having high cholesterol, etc., because there are things that you can do to reduce your risk and potentially even reverse cirrhosis. So, Tamar, I want to pick up the conversation where we left it in terms of prevention. So, we talked a little bit about going to see your doctor, checking out your liver, doing that blood test that you mentioned, which could give us a sense of our risk. So let's suppose we know that we're at risk. What happens then in terms of screening and surveillance? I understand that there's some new guidelines out. Can you talk a little bit more about that?
Sure. So we recommend, and the we here is the American Association for the Study of Liver Disease, which is sort of the premier liver society. But many other societies, the European, the Asia Pacific, as well as NCCN, recommend that patients with cirrhosis undergo ultrasound with AFP every 6 months. And the every 6 months is based on the doubling time of these tumors. And so for anyone with cirrhosis, we would recommend that screening regimen. Now, the AFP, which is called an alpha-fetoprotein, it's a tumor marker that can be secreted by some liver cancer cells, can be helpful. If it's very elevated, it's usually a prognostic factor. And for a long time, it was sort of plus minus. The recommendation was ultrasound plus minus AFP. But more data has come out to suggest that the AFP really does help us with specificity and sensitivity in terms of ultrasound, which can be, a pretty insensitive test. So one of the major changes in the latest guidance document that came out from AASLD is to include AFP every 6 months with that ultrasound.
So that sounds like that's a lot of imaging. I mean, every 6 months for the rest of your life. Can you talk a little bit more about, are there gradations of cirrhosis such that some people need it and some people don't? Or is this something that, if your doctor says, based on the blood work that we talked about before the break, that you do have cirrhosis, that you really should do this for the rest of your life every 6 months?
So for now, that is the recommendation, but we are desperately working on refining risk scores because there are gradations of risk. And we know that the more advanced cirrhosis is, the higher the blood pressure in the liver, the more likely it is that the risk of liver cancer goes up. Most people with cirrhosis have anywhere from a 1% to 7% per year risk of developing liver cancer. We need to figure out who's more in the 1% or under 1% and who's more in the, say, 7 to 10%. And there's a lot of different, there are many different investigators trying to develop risk scores based on both clinical factors as well as some genetic factors and other exposure factors. So I do believe we'll have better risk scoring probably within the next 5 to 10 years. But until that time, it's really important to stick with your screening.
This type of screening is covered by most insurances, I'd imagine?
Yes, absolutely. Especially, obviously you need the diagnosis of cirrhosis to qualify in terms of insurance coverage. But once the diagnosis of cirrhosis is, on the chart, so to speak, we've never had pushback with ultrasound every 6 months.
What happens if they actually find a cancer. I mean, with most screening tests that we talk about on this show, the idea behind screening is really to find this cancer early when it's most treatable. Is the same thing true for liver cancer?
Absolutely. So liver cancer is just like any other cancer when it comes to early detection. We know early detection saves lives because the earlier you can detect a liver cancer, the more likely you can receive curative treatment in the form of either surgery to remove the tumor or what we call local therapies to destroy the tumor. So that is key. It's very important to detect cancer early. Once you have something that shows up on an ultrasound, it's not a terribly sensitive exam. And so if what is seen on ultrasound is over a centimeter, then the recommendation is to get dynamic contrast enhanced imaging, either a CT scan or an MRI, to make a definitive diagnosis of liver cancer.
So wait, the diagnosis is made on CT and MRI and not on biopsy? Most of the time on this show, we're always talking about getting a tissue diagnosis to make that diagnosis of cancer.
Right. So this is where liver cancer actually departs from other cancers. So because of the organ's vascular supply and the way liver cancer develops, we are able with near 99% certainty to say on imaging whether something is a liver cancer or not. So there is a system, a classification system for us that radiologists use to determine whether this is a definitive cancer. And if it's a definitive cancer, it does not need biopsy. Now, that is a problem for a number of reasons. We don't have great biomarkers for prognosis, treatment, response to treatment in liver cancer. And a lot of that, I think, has to do with how little biopsies have been done over time, because we have a lot of resection specimens, but those are early cancers. We don't have a lot of advanced cancers because they're not biopsied. And so I think the field is moving more towards consideration of biopsy, especially as we get better and better with tumor profiling. Because the sort of drivers of cancer and in liver cancer are so complex, I'm not sure we'll ever find a true mutation that is what we say in, like canonical, like the Holy Grail that we can absolutely target. But I think if you look at other cancers, we really are employing multimodal therapy, so different treatments to target different upregulated and downregulated cascades of cancer, drivers. So I think while, we don't have to do a biopsy, more and more people are leaning towards doing biopsy, especially if they're going to instrument the tumor. For example, for those patients who get local treatments, if you're already burning a tumor, for example, it's reasonable to take a biopsy. So the newest guidance really does say that biopsy can be offered anywhere along the spectrum of, a tumor that looks like it's growing perhaps, but may not meet criteria, to a bona fide, criteria met tumor that we can call an HCC by imaging. There's still a lot of debate in the field about this because also peculiar to liver cancer, it is like the only solid organ tumor for which transplant offers a cure, and like decades-long cure. Many people live for, 30 years, more than that after transplant. And so a lot of the surgical field is concerned that by doing a biopsy, we could potentially seed tumor. But if you really look at the seeding rates over time and with much better technology than we had, say, 20, 30 years ago for doing biopsy, those rates are very, very low.
So let's talk a little bit more about kind of the treatment of liver cancer. You mentioned that many of these, if they're caught early, may be amenable to either surgical resection or local ablation. But you also mentioned kind of multimodal care. And we talk a lot on this show about multidisciplinary management of cancers. Can you talk a little bit more about at what point in a patient's trajectory, things like chemotherapy or systemic therapy or radiation might come into play?
Yes. So it's a moving target. There's a lot of data that suggests that maybe we should be thinking about systemic therapies earlier. We don't really use chemotherapy in liver cancer, at least not conventional chemotherapy. We use a combination of small molecule therapy, like tyrosine kinase inhibitors, and drugs that affect the immune system's ability to detect and essentially kill cancer. So those are more the immuno-oncologic therapies. So conventional chemotherapies have not worked in liver cancer, which is why we are using these other agents, which are now being used more and more in other solid organ tumors. And in fact, we've taken a page out of the pioneering work that was done in other types of tumors. So, when we've looked at liver cancer in a very linear way. So, early stage disease you treat with either resection, cutting it out, or, these local regional therapies. And then later stage disease, when it's gone, into the blood vessels or perhaps, external to the liver, that's when you would employ those more systemic therapies. And now we have data to suggest that actually we ought to be thinking about moving systemic therapies into that more intermediate disease where people may have more than one focus of liver cancer, which is very common to present with more than one tumor in the liver. And so I think over time, we're going to have to really think about the way we've looked at liver cancer and think about all the drivers, the immune drivers. It's not just there's a spot and I want to destroy it or cut it out. It's much more of a field effect in the liver because the cirrhosis is really driving the cancer, and the cirrhosis affects the entire liver, which is why recurrence rates are really high. Even after you might cut out one focus of liver cancer, there's still a 50% recurrence at 2 years and a 70% recurrence at 5 years. And to me, that's the field effect. We really need to think about how best to think about the cancer environment and how best to treat that over time. And with the use of these systemic therapies, we are seeing people live much longer than they used to live. So I think we're really seeing a significant change in the way we approach this tumor, which actually means we require now more than ever really good multidisciplinary care. We need the oncologists at the table from the get-go to really think carefully about these patients along the trajectory of their care. And a lot of what we can do in liver cancer is actually really dictated by underlying liver function, which is why it's somewhat peculiar, but it's usually the hepatologist that brings that case to tumor board, because we're the ones who are sort of managing underlying liver dysfunction, making sure we optimize a patient's liver function. And we need to hold hands with oncology and every other discipline, interventional radiology, radiation oncology, throughout the care of that patient to make sure we can maintain an optimal liver function so that they can get the treatment they need.
Yeah. I mean, it sounds like with the recurrence rates and the field effect that you mentioned, the holy grail really might be to figure out how do you prevent cirrhosis from actually turning into a cancer or leading down the path to a cancer. Has there been any work on that?
So I think the problem is the relative number of different pathways that lead to cirrhosis, and also the fact that a lot of this research has to be done in a multi-center fashion. So we're not there yet, but I think many of us are looking at those, looking at that cascade from cirrhosis to cancer.
Dr. Tamar Taddei is a professor of internal medicine and digestive diseases at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next week to learn more about the fight against cancer here on Connecticut Public Radio. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.